cardiology, as well as Mike Breyer from nephrology. As I mentioned to you on Tuesday, or for many of you who were there, they have been inducted into the Honorary Society, the Southern Society for Clinical Investigation. So congratulations to them. If you see them, say hello and congratulations. It's important because it's a regional society that induction into it is based on accomplishments and consideration of potential by the council members. And it gives us visibility, and we're now one of the institutions that has the highest number. Not the institution with the highest number, but one of them with the highest numbers in the Southeast, which is terrific. Now, today, back in 1785 was the birth of William Prout, P-R-O-U-T. And you would say, who is William Prout? Who is an English biochemist who did some work in metabolic chemistry, but he is known for the Prout hypothesis, which dates back to 1815. And that hypothesis states that the atomic weights of all elements are exact multiples of the atomic weight of hydrogen. I would have assumed that would have been logical, but I guess it's not, since hydrogen is one. But, you know, that assumes that the atomic weights should all be whole numbers, so I guess that there was something to that. But what's interesting to me is you saw me limping coming up here because about 2 months ago, Dr. Roberts and my nephrologist, where's she? Eleanor, diagnosed me with gout. And this man in 1818 isolated urea for the first time and uric acid. He also, 6 years later, found hydrochloric acid in the digestive juices of the stomach. And he was the first scientist in 1827 to classify the components of food as carbohydrates, fats, and proteins. And in 1920, Ernest Rutherford named the proton, P-R-O-T, in his behalf, P-R-O-U-T. So, but today is about the lung. It's about pulmonary fibrosis. And today we should remember Oscar Auerbach, A-U-E-R-B-A-C-H. Oscar Auerbach, you should know that name. He died in 1997 at age 92. He was born in 1905. He was an American pathologist who did a lot of work, and one of the first to really confirm the relationship between smoking and lung disease. And in fact, it was much of his work that was cited by the Surgeon General's landmark study from 1964 about the dangers of smoking and lung disease. Before his time, there was a lot of data on statistical analysis linking smoking to lung disease. What he did is he cut the slices of lungs of multiple patients who were smokers and correlated the amount of damage in the lung to the amount of smoking that they did. And so that was very crucial for that report to have a very strong impact on this society and smoking. And smoking has now been linked to a number of other diseases of the lung, including idiopathic pulmonary fibrosis, which brings us to the speaker of today. I've often said that one of the fun things about being in academic medicine is you can watch your friends evolve over time. And you meet a lot of great people along the way. And it's been a pleasure for me to watch Mitch Olman evolve the same way he has watched me. We've pretty much about the same time, went to medical school about the same time. And he has become an expert in the area of pulmonary fibrosis, for which we have exchanged ideas over the years and have worked together. Let me tell you a little bit about him. He's from Queens, New York. Is that correct, Mitch? Obtained his MA in anatomy at Columbia. He went to NYU for medicine, graduated in 1983. He did his internship and residency training at the University of Chicago in internal medicine. Then went off to the West Coast to do pulmonary and critical care medicine at UC San Diego. Then he moved back and he came to University of Alabama in Birmingham. And of course, that's where I met Mitch, because Atlanta and Birmingham are not too far from each other. And he was there from assistant professor to professor of medicine in 2009. So he stayed there all his career. But in 2009, he moved to Cleveland because he loved the weather up there. And he's now in the Department of Pathobiology at the Lerner Research Institute at the Cleveland Clinic. Mitch is a physician scientist. You'll see some of his work here. Mainly he's going to talk to you about idiopathic pulmonary fibrosis because he takes care of patients and he does clinical research in that area, but he also does basic science research and is NIH funded to do work in the area of coagulation and pulmonary fibrosis, which has been his passion over the past 2 decades. He's also been at the VA. He was many years at the VA system funded by them. I've met him multiple times at NIH study sections. He serves on editorial boards, and it's a pleasure to have my friend Mitch Olman. Mitch?
you can all hear me in the back. And I want to say it's a pleasure that both to me and to you that you have such a dynamic leader here who's going to guide the University of Louisville to greater heights, I'm sure. So we're going to talk about idiopathic pulmonary fibrosis, new approaches and challenges. And it's a very exciting time to be working in IPF because throughout both our entire careers, we did not have any effective therapy. And just in the past year, there's now 2 FDA-approved drugs. And so instead of just being able to tell a patient, well, we have nothing to help you, they can now read from a menu and possibly find therapeutic benefits. So as far as what we're going to talk about today, we're going to talk a little bit about the new ATS definition, how you define IPF, what are our new understandings of what causes, or at least the underlying biology of IPF, talk, compare and contrast the new therapies that are recently approved, discuss some new and ongoing challenges to improve the therapies, and I'll show you a little bit about my research where we've identified new targets for therapy in IPF. So I like the historical approach that Dr. Roman gave, and this is a little bit more history. Believe it or not, Austin Flint of Murmur Frame was the first person to actually describe the pathology in IPF, and he talked about fibroid exudate, which is permanent, dilation of the bronchial tubes called bronchiectasis, and even talked about clubbing, knowing the extremities of the fingers to become notably bullous in this affection. Sooner or later, it's terminal. So IPF has been around for 160 years or so, and it's only recently that we have effective therapies. So there's about 200,000 patients in the U.S. living with IPF, and there's about 40,000 new cases per year. And for many years, we all thought that this was the clinical course of IPF, slow, inexorable progression with a median survival of about 3 years. But recent trials and careful scrutiny of the placebo group in those trials has led to new insight in that the course of IPF is highly variable, and it includes slow progressors, and more importantly, the majority of patients with IPF have slow progression followed by brief periods of worsening, recently called acute exacerbation. And so we've learned that the majority of patients with IPF will progress in this way, and that makes clinical trials very difficult. So how do you make the diagnosis of IPF? What is IPF first? And I'm not a fan of nosology, so I'm simply going to say that there are many known causes of what looks like pulmonary fibrosis, and a large part of the clinical time spent in people who see patients with the disease is ruling out these multitude of causes. And so when you see somebody with apparent pulmonary fibrosis in the clinic, most of your mental effort will be spent talking to them and seeing if they have any known causes. And so this feeds into the ATS-ERS definition of how do you make the diagnosis of IPF. And first off, you have to have patients in the right age group. But the most important part of this, the first step, is exclusion of other known causes of interstitial lung disease. And how do you do that? And many famous people have taught Jesse and I over the years that you take a history, and then what do you do after that? You take another history. And it's often, this is a disease where the attendant comes in after the medical student and the resident and the fellow have taken the history. The attendant comes in and takes the fourth history when he finds out they have a pet at home, or they spend their career shoveling bird droppings, or they worked in a mine for 40 years. And so it's the fourth history that the attendant can come in and learn that their cause of interstitial lung disease is one of these. That said, having done that, there's really no blood test to exclude these causes. All the different immune panels and viral panels and exposure panels only tell you that a patient's been exposed to a particular toxin. It doesn't tell you that that toxin or infection has caused their disease. So the history is the critical feature. That said, if you've done a reasonable job excluding other known causes, then the recent change, or the past 5 years perhaps, is that the reliance on high-resolution CT and a typical pattern, which I'll show you in a minute. In the absence of that, then most people would recommend combining the results of the high-resolution CT with the results from a surgical lung biopsy and have what's called this multidisciplinary discussion to then ferret out the diagnosis of driver. So it's a sort of a pretty simple, laid it out pretty simply. Take history several times, then look at the HRCT, and if it's not typical pattern, if it's anything but typical, I'll show you what that is, then you have to do a HRCT, get a lung biopsy, and have it down with your pathologist and radiologist. And I think if you do that, you're basically doing the best job that can be done. All right, why is this not going? Okay. So what are the typical features of HRCT that essentially make the diagnosis of pulmonary IPF? There are several. Basically 3. One is that they have to have a basal and subpleural predominance, and this is an example of normal HRCT, and this is an example of a patient with IPF, and you can see here in the lower lung zones, and you can see that the predominance is along the pleura. They have to have reticular abnormalities, and those are these little fine lines here. And the most important part of the definitive diagnosis of IPF by HRCT is the presence of honeycombing, which are these little cysts-like things that look a lot like honeycombs. When you don't have that, you can't look at the HRCT and say this is a definitive IPF. So if you remember anything, you remember this. The other part of this is that a number of other diseases can cause an HRCT that looks somewhat similar to this. So you have to make sure that they don't have other diseases like emphysema or listen. So they can have some features of that, but it can't be the predominant. So if you remember anything, remember honeycombing and the absence of other predominant diseases. That said, most of the time you'll get an HRCT read that includes some of these other findings that are not those 3 things I told you about. And so when they have any of these other findings, and this example is a patient with hypersensitivity pneumonitis, and you can see some ground glass, some mosaic attenuation, so the fact that it's an upper lobe disease. So when you get that, even though that says fibrosis, it's not idiopathic pulmonary fibrosis. It makes it very simple. It's something else. And so let's say you got that second CT scan. So you go on to surgical lung biopsy, and this is a patient with normal lung. You can see the nice alveolar walls, the normal terminal airways, as compared to a patient who has a specific pattern that's called UIP, which is just usual interstitial pneumonia. It's just a fancy word for the pattern of the pathology. And what's critical here is several things. One is, this is a biopsy, here's the pleura. So the disease, the fibrotic disease here, is predominantly subpleural. What you can also see here is what's called the fibroblastic foci, which has hyperplastic epithelium and a mix of inflammatory and fibrotic cells. And what's also critical here is this is adjacent to areas of normal lung. So the critical features, just like on the HRCT and the pathology, is a subpleural predominance, presence of fibroblastic foci, and adjacent areas of normal lung. And so when you get that, that is a typical pattern for IPF. But again, it's not a black and white thing. You could find areas of emphysema in patients with IPF. You could find areas of scar in patients with emphysema. So you have to, it's a judgment, it's a little bit of a judgment call. And this is what honeycombing looks on histology. You see large areas of scar with large open cystic-like spaces covered with hypoplastic epithelium. And so what's the algorithm? This is sort of the take-home message for the clinical people, is if you suspect IPF, you spend a lot of your mental effort taking a history, doing an exam, and is there an underlying identifiable cause? And don't underestimate time spent at this point in the algorithm. Because you see a lot of patients who go down this way only to get a good history and they find an identifiable cause. So decide, is there an identifiable cause? If there is, then it's not IPF. That's very simple. If there's not, then you go down the diagnostic algorithm, which is fairly simple. Just take an HRCT, and if it has those findings of subpleural predominance, particular abnormalities, and honeycombing, then you're done. Then you have a diagnosis of IPF. If it's got anything else, then the best suggestion is to take a surgical lung biopsy, and this is somewhat controversial. And then depending on what the findings are on surgical lung biopsy, if it's the typical findings of, like I showed you, then you have a diagnosis of IPF. If it's not a typical finding, or it's a mixed pattern, then the best thing to do is have a case conference where you meet with the radiologist, the pathologist, and experienced pulmonary clinicians, and make an adjudication on a patient-by-patient basis. And at the clinic, we present all our pulmonary fibrosis patients in what's similar to a tumor board, where the people get together every week, we discuss every patient, and so we have this multidisciplinary discussion on basically every patient. And I think in some ways that is perhaps the state-of-the-art approach. But it all starts with a smart history. So this is just outlining what I just said, which is if you got the clear HRCT, you're done. If you have uninterpreted or not clear HRCT, then you can get lung biopsy, and then depending on the multidisciplinary discussion, the pattern on the pathology and the pattern on the HRCT and the clinical history, you either make a diagnosis or not in the multidisciplinary discussion. So I'll pause for a moment to let that information sink in. Now that you got that, we'll move on to what causes IPF. And if I knew the answer to that, I would be in a much bigger stage. But there are, I think the current understanding has shifted away from the decades before idea that it's driven by ongoing acute inflammation to the relatively 10-year or so idea that it's due to dysregulation of the normal reparative process. And Dr. Roman was one of the leading proponents of this when it first came out. So our current understanding is that there's some diffuse cellular injury, which is often unrecognized and might be predominantly an alveolar epithelial injury, because in many types of lung injury, the type 1 alveolar cells being thin and spread out are susceptible, much more susceptible to injury than other cells. And then that's followed by, in some cases, chronic inflammation, which is often hard to detect, but if you do subtle analysis of both animal models and patients, there is evidence of chronic inflammation. And then somehow or another, this combination of problems leads to dysregulation of the normal reparative process. And back in the 70s, when I first learned about lung pathology from Charles Carrington, who was the first author on the paper that described BOO, he taught me that the lung is a dumb organ in the sense that it only knows several modes of repair. And so if the repair is dysregulated, independent of what the original injury is, the lung is going to repair according to its own program. And when you combine that thought with the fact that by the time you see patients in your office, they already have fibrosis. So that the focus of research, both in my program, Dr. Roman's, and many others, has been not in identifying the mysterious cause of the initial injury, but in identifying how the repair process can be dysregulated, both from a practical standpoint and a theoretical. And when you add in the fact that over the past 20 years, there have been multiple unsuccessful trials of immunosuppressants, of endothelin receptor antagonists, of various other additional immunosuppression, and I'll show you a little data on this, which is a trial that I went in, is on anticoagulants, that we have to shift focus. And so this is just showing our dirty laundry, the recent failed, several recent large NIH-funded multi-center clinical trials in the U.S. that all failed. In this case, this is the use of warfarin, where there was an increase in mortality in the warfarin treated compared to placebo, not due to bleeding. And this is the NAC, N-acetyl predase and NAC. Predase was the standard of care for 20 years. And what we showed in this trial, and this is how important it is to do randomized controlled trials, is that predase and NAC were killing people compared to placebo. And here is NAC alone, N-acetylcysteine alone, had really no effect. So what do? Well, we go back to the woodshed or the drawing board, and we think again on what causes IPF. And what I'm showing you here is the different pathways that can be divided in terms of dysregulated repair. So I'll just go over this and just get a broad sense for what we're talking about. So there are pathways related to epithelial cell death or reprogramming. There are abnormal pathways related to immune activation, and there's two current new therapies that are IL-13 antagonists that are directed against inhibiting perhaps this immune activation. And there are pathways related to thrombosis in the alveolar space and remodeling of the fibroclot. And this is where warfarin, this basic science is what promoted warfarin use, which was ineffective. That said, there are newer anticoagulants that are direct thrombin inhibitors that could potentially have different effects on thrombin receptors independent of fibrinolysis that I think are worthy of being evaluated. And then the new drugs and the ongoing clinical trials now are directed primarily at the repair process. And so we'll talk a little bit about nintedanib and pirfenidone, which affect fibroblast recruitment, invasion, proliferation. And we'll talk, and they also have effects on myofibroblast differentiation, which is the primary effector cell of scar in the lung. And there are additional trials looking at a lysyl oxidase inhibitor. And lysyl oxidase is an enzyme that's involved in cross-linking of collagen. And you can imagine that if the collagen is less cross-linked, then the lungs are less stiff. So most of the new drugs are directed at the repair phase of the overall process. So what about the new drugs? So I'll first talk about pirfenidone, then nintedanib, and then we'll do a little compare and contrast. So as far the history of pirfenidone goes back about 10 years now. Initially in 2005, there was two Japanese trials where they looked at 300 patients and had a slower rate of decline in the treated group. And these two trials led to approval of pirfenidone in Japan in 2008, which is 7 years ago. Then they did with the same similar kind of trials, only in the U.S., called capacity trials. And if you do a meta-analysis that Cochrane did in 2010 of the Japanese trials and of the capacity trials, it looks like there's a benefit of pirfenidone in progression-free survival. And so those three trials led to approval of pirfenidone for the treatment of IPF, basically everywhere except the U.S. And in India was the first in 2010, and then Canada was the last in 2012. But the U.S., because of some details about the way some of the trial data was analyzed, was not satisfied, and they told Intermune to go another trial, which they went ahead and did in the U.S. called Ascend. And what's the difference? And so what they did with Ascend was they went back and looked at their own data of their previous trials and selected the group that was most likely to respond. So this is a very selected group of patients with pulmonary fibrosis. I can't emphasize that more. And so what was different about it is they were very careful in excluding patients that had any evidence of emphysema along with their pulmonary fibrosis. And they also adjusted the range of severity to skew a little bit more towards those who are more impaired with pulmonary fibrosis. And they deleted some entry criteria, that is the ability to walk on a treadmill for 6 minutes and whether they need supplemental oxygen. Those were deleted. And that was based on looking at their own data post hoc. That said, they were smart enough to, well, the FDA required it, to add central confirmation and adjudication. And that's a real issue when it comes to clinical trials, because as we talked about at the beginning, the interpretation of the high-res CT and the interpretation of the pathology isn't always uniform. And so by having central confirmation and adjudication of the diagnosis, they could at least have a uniform criteria. And that turns out to be really important and will probably cause a major difference in what we find in the community in patients with IPF when we use the same drugs as compared to what was seen in these trials. And so this is required by FDA. So the advantages of doing this sort of follow-up trial is more real patients with IPF. They don't have emphysema superimposed, which of course can affect mortality. And it's a relatively sicker population with more severe impaired vital capacity and worsened diffusing capacity and a higher incidence of oxygen use. So this is a very selected group. And when they did that trial, they found that there was a benefit of pirfenidone in that select group in terms of the slower the decline or in this case, the percentage of patients with IPF that had a decline greater than or equal to 10% was less in the pirfenidone group as compared to the placebo group. And that was significant. It was a composite endpoint and that included mortality, but the findings were primarily driven by the decrease in forced vital capacity. So that was a positive trial, and the FDA-approved pirfenidone. Oh, I'm sorry. And there were side effects that are notable. Primarily, rash was the biggest one, along with upper GI symptoms. That said, even though they were both fairly common, only a small percentage, 2% or 3%, had to stop the drug due to those trials. So probably if you live in Miami, you don't want to start pirfenidone because primarily it was a hypersensitivity to sun. But I don't see that a problem in Cleveland, and we'll see about Louisville. So the other part of pirfenidone that's driving some of the comparison is that even though I showed you it has mechanisms of action related to fibroblast recruitment and myofibroblast differentiation, the precise molecular mechanism by which pirfenidone works has yet to be characterized. That's different than nintedanib, which has been tested in terms of its molecular effect, and it affects a number of growth factor receptor activity, including PDGF, VEGF, FGF, and even some of the signals related to TGF-beta are blocked by nintedanib. So even though that's at first glance it looks like the molecular mechanism, we really don't know which of those molecular effects, or even if any of them, or if it's the combination that actually has this antifibrotic effect. So even though there is a molecular mechanism that one can tag, that doesn't mean that we understand why the drug works in fibrosis in vivo. And that becomes important when you think about whether you're combining these drugs or using combination therapy. So what about the data on the trials of nintedanib? There was a dosing trial that I won't show you the data on. This is the phase 3 trial, and there were two, and it encompassed about 1,000 patients in 20 countries, and it looked at 1 year at 150 BID dose, and the selection criteria were roughly the same as that in nintedanib. They had to have mild to moderate disease with a vital capacity greater than 50 and a diffusing capacity greater than 30. And so roughly the same level of severity as the pirfenidone trial. The major endpoint was another look at essentially the same parameter. Instead of looking at the percentage of patients that declined above a certain threshold, which is what pirfenidone did, they looked at the rate, slope of the FVC decline as the primary endpoint. And so the data are here. Here is the trial 1 and trial 2, and basically you can see in placebo they declined with 220 something mils, and with the nintedanib it was about half that to 110. Same with the second trial. So it did slow the rate of FVC decline, met its primary endpoint. There were side effects of nintedanib too, only in this case they were perhaps, depending on your view, more severe in the sense of, let's see what we got here, 60% of patients had diarrhea. That said, they had a management scheme where you could reduce the dose, add some anti-diarrheals, and in doing so, only 5% actually had to discontinue the drug due to diarrhea, roughly comparable to 2% on the rash. And then there were a few patients who had LFTs that were elevated that also had to discontinue therapy. So both drugs have side effects, but they're different side effects, but roughly comparable percentage had to stop drug. So head-to-head, if somebody comes to you and you say, well, I have one drug, which should I use? Let's do a little careful analysis on the trials and what they mean. So if you just compare the head-to-head, the pirfenidone ASCEND trial versus the nintedanib trials, there are differences in the entry criteria. The pirfenidone patients had a considerably lower forced vital capacity. They had more scar in their lung compared to nintedanib. And in fact, this is close to, in fact, normal. This is indistinguishable from normal in terms of the vital capacity. So the patients some of the patients in the nintedanib trial were very mild pulmonary fibrosis. Additionally, in the pirfenidone trial, they had worsening diffusing capacity, so again, another measure of impairment, although that's probably not different than 47. But this is a big point. The ASCEND trial used the formal ATS-ERS criteria, that being honeycombing on the HRCT or surgical lung biopsy. Whereas in the nintedanib trial, not only were they have mild pulmonary function impairment, but honeycombing was not required. So it's very likely that not only was this group more mild as a group, but may have included those with diseases that were other than IPF or had IPF that was mild plus another disease. So that muddies the waters a little bit. So a head-to-head comparison of the results is quite interesting. So on the this is nintedanib. So placebo had a decline of FVC of about 220. The treated group was about half of that, about 110, a delta of about 110. The pirfenidone group had the same difference, about 110, 116 here, but the placebo group declined much greater, close to 300, and the treated group was closer to the placebo group in the other trial. What's going on here? So what is going on here is a general principle in how do you evaluate clinical trials. In this trial, how do you evaluate missing data? That's a critical feature of your interpretation of clinical trials. In this case, if a patient either dropped out or died or missed an appointment or in any way did not complete the trial, they assumed that their last FVC was equal to 0. So you can imagine that would lead to a huge mathematical decline. That said, they did that in both groups. And however, if the mortality in the placebo group was higher, you have a lot more zeros in this group than you do in this group. So that led to two mathematical consequences. One is that the placebo group absolute FCC decline was much greater than the nintedanib group, and also may have biased a little bit on the delta. So if more patients died here, you get a lot more zeros, so this would be a greater decline. So maybe the difference is somewhat amplified by the way they imputed missing data. Whereas in this trial, they went back to whatever the FVC was, the last FVC measurement. So if the patient had a good FVC and then died the next day, they included the good FVC. So it's a little bit of a bias in both the absolute decline and the difference in the pirfenidone trial. But that said, there was a more tightly selected group that had IPF and more severe. And so what about the practical aspects of the drugs? Well, pirfenidone, it's 2,400 milligrams per day. So you have to take 9 pills, 3 pills 3 times a day. Nintedanib, you take 1 pill twice a day. That's, for some people, that's a big deal. What about the side effects? Pirfenidone, rash and upper GI are the predominant ones. Nintedanib, diarrhea, more common, perhaps disconcerting, but at least if you speak to the Boehringer Ingelheim people, it's manageable in most cases. That remains to be seen in patients who are having diarrhea and taking a drug that may or may not be tremendously effective. So we'll see what happens in terms of patient response to this. As far as efficacy, it's roughly equivalent given the vagaries that I just told you about. Both slow the FVC decline in a year by about half. The cost, both ridiculous. $95,000 a year for either one. The good news is, though, that pirfenidone is approved worldwide. And you're going to laugh, it sounds like a Sicilian just fell off the back of the truck thing. But there is a guy that you can email in India, and he will set you up with Indian manufactured pirfenidone, which has undergone somewhat rigorous testing and found to be equivalent in many levels to the US, and you can get that for $1,200 a year. So that's going to become a major issue for those without the $95,000 or without the insurance that's going to pay for it. And then the availability in the US, in both cases, is specialty pharmacy, and there will be, hopefully, as much as I like being in control of my own destiny, hopefully the insurance companies will, and they're already starting to do, limit those to actual IPF patients rather than just anybody who has a scar in the lung. And that remains to be seen how that falls out. So you can make your own judgment as to what you want to do. So in summary of this data, in mild to moderate IPF, and I emphasize all those things, mild to moderate, and that it is IPF, both drugs slow the rate of decline by about half. They don't cure the disease, they slow the rate of decline. The mortality results, which I didn't go over, should be interpreted with caution, that's why I didn't go over it. Side effect profile is different, but acceptable. So there are a lot of unanswered questions that I'm sure Dr. Roman and the Pulmonary Division have been mulling over for several months now. And that is, importantly, they should be mulled over. What is the effect on more severe disease? We don't know. Do these drugs prevent exacerbation? We don't know. And as you recall at the beginning, many patients with IPF have that acute exacerbation as a worsening. Are there effects beyond 1 year? But we talked about the median survival being between 3 and 5 years. We don't know if you continue the drug, do you continue to slow the decline, or do you catch up, or do you worsen? Do they work in other interstitial lung diseases besides IPF? We don't know. Which drug, and I think the future is starting to go in this direction. Which drug, if any, should be used in a specific patient? Can the drugs be used together? And when I talk to my pulmonary hypertension colleagues, they say the IPF field right now is very much like the pulmonary hypertension field was 10, 15 years ago, where they had 1 or 2 new drugs. And what happened within a year is that private docs and, frankly, all docs ended up putting drugs in combination. And that's where with no data to support it, they just did it. And that's where the mechanism of action might be important in terms of whether or not these drugs have a similar molecular mechanism of action, or whether they would target different effects on the repair process. And ideally, the way I see IPF treatment going in the next 10 years would be like cancer, where you interrupt the pathway in multiple points. And even better, if we had markers of which point was more aberrant in which patient, you could target the therapy. So I think this is likely to happen pretty soon. It probably won't have clinical data supporting it, because when you treat the individual drug companies, they're not gonna sleep with the enemy and do a trial with both drugs together. It's just not gonna happen. Cost is an issue, but as long as the insurance company, at least in the U.S., is willing to pay for it, and with the proviso that you'll probably be sending some emails to India soon. So what are the ongoing challenges, and where is this field going in 10 years? It's an exciting field. Big pharma is involved. They're throwing money around. There's drugs involved. In fact, this ATS meeting this year, I've never seen more people being taken out to dinner by pulmonary fibrosis drug companies this year than in 25 years. So there's a lot of buzz around there. So we can use that to try to identify new targets, new pathways. And as I said, I think we're going to the point where we're targeting multiple pathways of fibrogenesis. We can hopefully identify clinical and prognostic heterogeneity in patients with IPF, and in doing so, we can design a better trial. That means better in the sense of more focused, better in the sense of cheaper, faster, and more likely to be of attraction to drug companies. And this is already ongoing. MUC5 turns out to be an important gene that helps with stratifying patients with prognosis. There are others. And then where my lab is interested in is to identify the biological heterogeneity. That is, of all those deranged pathways, is there specific derangements in given patients? And then if so, can you target that? And so this is in many ways the ultimate personalized medicine. And this is real personalized medicine, not hyperbole. So we already did that. So now in the last 5 minutes or so, I'll tell you a little bit about what we're doing in the lab. And as Dr. Roman alluded to, for 20 years or so, I've worked on steering proteases in the coagulation fibrinolytic family and how they can affect fibrosis. And over the past 3 years, we have an exciting new area in the lab that I'll show you some data on, and that's working on Mechanotransduction. What is that? That is, in a broad sense, the ability of biophysical properties of the cell, mechanical properties of the cell or matrix, to transduce signals and change cell behavior. And this is a relatively new area, and it applies to many different aspects of biology and disease. For example, stem cell fate is determined by mechanotransduction. Epithelial mesenchymal transition is determined by mechanotransduction. And I'll show you some data showing that pulmonary fibrosis is also likely important pathways of mechanotransduction. So for many years, and many of the drugs that we're currently using to treat IPF or to try to treat IPF are based on the notion that other cells, either inflammatory or resident parenchymal cells, make stuff that are soluble factors that then ultimately affect the fibroblast and makes it active, makes it proliferate, makes it migrate, makes it remodel the matrix. And that it's the production of these soluble factors impinging on the fibroblast that causes fibrosis. And that was the paradox for many years. But more recently, there's been an acknowledgement that the properties of the matrix, that is the biophysical properties of the matrix, can affect fibroblast behavior just as the soluble factors can. And this would include not only the biochemical composition, that is whether the matrix is collagen or fibronectin, but the organization of the fibers themselves, whether they're lined up or whether they're in random directions. This includes the pliability or the stiffness of the matrix itself can drive the fibroblast to behave in one way or another. And it includes the dimensionality of the matrix. That is whether it's on a flat surface or whether it's in a three-dimensional environment. It's been increasingly recognized that all these components of the surrounding tissue of the fibroblast can affect the fibroblast behavior in fundamental ways. And so, what is an example of that in relation to pulmonary fibrosis? Well, if you look at a fibroblast and if you give it a mechanical signal and you give it TGF-beta, you can turn a fibroblast, which is a fibroblast, into a myofibroblast, which is a super fibrotic cell. And these cells make profibrotic cytokines, and they're very different structure of fibroblasts. You can see all these lines here. These are what's called stress fibers, which is essentially the steel girders of the cell. And furthermore, they have very tight adhesions to the surrounding matrix. And these are generally assumed to be a major profibrotic cell, not only in the lung, but in the heart, skin, kidney, liver. And so the critical aspects of how you make a myofibroblast are two. You need some sort of mechanical signal, and you need TGF-beta. So what were the questions? That's the background. What's the questions? Well, what's the nature of the mechanical signal? How's the mechanical signal sensed by the fibroblast? How's it transmitted into the cell to make a signal? And what are the molecules within the cell that affect that phenotypic change into this super contractile profibrotic myofibroblast? And so our research is directed at these questions. And to cut to the chase, since we don't have time, we basically identified an ion channel called TRPV4 as transient receptor potential vanillite 4. And that is an ion channel that sits on the surface of the cell, and it's activated by stretching. And so it was first discovered in worms that as an osmolar sensor, that is when the worm swells up because its osmolarity changes, this channel opens up, and when it opens up, it lets calcium come from the external part of the cell into the inside of the cell, and that initiates a whole series of signals that changes cell behavior. And so what we identified was that fibroblasts in the lung express this channel. And furthermore, if we grow fibroblasts, as we did in this experiment, on varying matrices that are very stiffness, so this is equivalent to the stiffness of a normal lung, and this stiffness is equivalent to the stiffness of a fibrotic lung. And so if you treat fibroblasts that express this receptor with TGF-beta, and you look at calcium, in this case we measured intracellular calcium, what you can see is the stiffer the matrix, the fibroblasts that are grown on a stiffer matrix when treated with TGF-beta have an increase in calcium influx. But then when we block this channel, which we've done here pharmacologically, but we've also knocked it out, you can block that calcium response. So what this experiment tells us is that TRPV4 is responsible for the stiffness effect of increasing calcium in fibroblasts. Well, what about myofibroblasts? We found the same thing, in fact, that as you plate cells on stiffer matrices, equivalent to normal lung and fibrotic lung, you see more myofibroblast differentiation. And when we block this channel, you can block the stiffness sensing effect on inducing myofibroblast differentiation. So that this channel plays an important role in sensing stiffness, initiating calcium intracellularly, and driving myofibroblast differentiation. There's a lot more data which I'll show you at noon, but we also knocked it out in mice. And when you knock it out in mice and use an animal model that's reflective but not perfect of the human disease, what you find is that they get less fibrosis. So this is a trichrome stain of a wild-type mouse given bleomycin, and you see all the blue here is all fibrosis. And when you knock out this channel, they get much less. And you can quantify that as percent fibrotic area. And in the wild-type mice, 70% of the lung is fibrotic. And when you knock out that channel, only 20% is fibrotic. So massive protection of fibrosis. We also analyzed it biochemically. If you look at hydroxyproline as a surrogate for collagen, the wild-type mouse had a big increase in collagen. The knockout mice lacking the receptor much less. If you look at it at lung stiffness, the wild-type mice had a greater impairment in stiffness, that is stiffer lungs compared to the knockout mice. And if you look at it as myofibroblasts, in this case measured as smooth muscle actin, a marker of myofibroblast differentiation, the knockout mice had much less myofibroblasts as compared to the wild-type mice. So overall, somehow or another, this stretch-activated ion channel drives fibrosis in animals and in human cells anyway. And the last piece of data I'll show you on this is that, interestingly, if you look at lungs from normals and lungs from patients with IPF, or if you look at fibroblasts from normals and fibroblasts from patients with IPF, there's no difference in the amount of protein of this channel. And in fact, if you treat with beta, they have the same level of upregulation. So whatever the difference is due to this channel, it's not due to simply protein loss. But interestingly, if you look at the activity of the channel measured as calcium increase, you can see that patients with pulmonary fibrosis have a higher channel activity as compared to patients with normal. So we're spending a lot of time figuring out why the channel activity is higher with the same level of protein in patients with IPF. And it has to do with signaling interactions with other receptors. And that's what we're working on right now. And so our working model, and I'll show you a lot of data at noon if you have time. Our working model of what's happening is when TGF-beta impinges on its receptor, there's activation of PI3 kinase gamma, which is another signaling molecule, which then complexes with the TRPV4 receptor. They both translocate to the membrane. So that's what's happening. Even though the total cell protein doesn't change, the TRPV4 is going to a place where it can work. And when it does that, the activity goes up, responds to a mechanical signal, that is matrix stiffness. Calcium comes in, induces cytoskeletal remodeling, releases transcription factors into the nucleus, which then makes myofibroblasts and makes fibrosis. That's sort of our working model. We have a lot of data in this area. So if we have time, yeah, I got to show you this cool movie. So in reference to one of our last questions, what are the effector molecules in working this, what's the final common pathway? So excuse me. So we developed a system by which we took lung tissues and labeled cells and put them on top and looked at how these fibroblasts interact with normal matrix that's got the same biochemical composition, the same fiber organization, etc. And if you see on a normal lung, you can see the cell sticks out its what's called protrusions and then migrates. And that's what happens on normal lung. So it's got a purpose in life, right? Whereas on fibrotic lung, look what happens. It makes fewer protrusions, but they're in every direction, and the cell just doesn't go anywhere. So there's a completely different phenotype on the way cells interact with fibrotic lung and normal lung. Then we quantify that, and this is what it shows. On normal lung, the cell's got a purpose. Each one of these lines is an individual cell. It's got direction. It moves. On fibrotic lung, it doesn't. But what about myofibroblast differentiation? Well, on fibrotic lung, here identified as lesions, they make a lot more myofibroblasts than they do on normal lung. So on normal lung they move, on fibrotic lung they make myofibroblasts. And so then we went on to show that all these phenotypes are due to myosin. So when you inhibit myosin, and you look at how a cell moves on normal lung, remember before they had single protrusions and they moved? Well, if you inhibit myosin, they're making protrusions in every direction, and they're not moving, so they lose what's called cell polarity. Whereas on fibrotic lung, remember they had protrusions in every direction, didn't move anywhere. Now you inhibit myosin, and what happens is they turn into normal lungs. So they make less protrusions and they move, so they gain polarization. So now what we have is an integrated response of myosin has a different effect on cell behavior depending on whether it's interacting with normal lung or fibrotic lung. So that sort of ramps up the understanding of how cells interact with matrix to a whole new level. So I'll just finish with that and acknowledge the people in my lab who have done much of the work. Olman, who now has a faculty slot at the University of Maryland, did a lot of the TRPV4 stuff. Lisa is a PhD in biochemistry, who's working on the signaling in my lab. Brian and Rachel are both junior faculty in pulmonary medicine. Brian's working on the myosin story, and Rachel has an interesting new story that shows that TRPV4 is important in the ability of macrophages to phagocytose bacteria. So, you can imagine a cytoskeletal remodeling, and when you knock out TRPV4, the macrophages don't phagocytose. So this is a whole new area for TRPV4, that is infectious disease. And Katie does the animal model, and Susanna does everything else. And I'd like to acknowledge my external collaborators who provided reagents and advice. Thank you.
Thank you. Very well done. I like the idea that you brought the clinical enterprise, patient care, clinical trials, discuss the new drugs, and then we move into what the new area will be, which is quite exciting. I have two questions for you. The first one is, it's nice to give me all this data, but the patient is with you and he wants either pirfenidone and nintedanib. Which one?
Well, I would say that when in doubt, involve the patient in the decision. And so you could say that, assuming they have insurance, that the main difference would be the side effects and the number of pills per day from the patient tolerance. So I would say, do you want to take 9 pills a day? Do you want to take 2 pills a day?
So you have no preference.
It
becomes, from the activity standpoint, it becomes more of a preference from the patient based on potential side effects and costs and that sort of thing.
Yeah, I would say so.
Okay, I'll come back with my other question later. Yes?
Looking at the second medication, which I'm just, instead of butchering, I'm going to call the Nintendo-like.
Yeah, it's hard. Yeah.
Okay.
But, it took me a while to work on it.
But because the diarrhea is so bad, and knowing that an agent such as verapamil may work with cutting down on atrial arrhythmias, which I suspect some of your patients have, maybe some diastolic stiffness of the heart, has anybody considered putting a randomized trial of verapamil, non-verapamil to see if it would constipate them a little bit, help with the side effects, plus maybe help them do a little bit better on their treadmill time and their distance to shortness of breath, fatigue. I was just wondering if anybody looked at anything like that.
So it's very interesting you said that, because in fact I'm in the process of reviewing for a journal a paper that's looked at the ability of nifedipine, another L-type channel inhibitor, on pulmonary fibrosis in mice. So there may be a role for not only TRPV4 as a calcium channel, but more traditional calcium channel blockers in IPF. And so that's an exciting area and a good question.
I think it's good to assume that if we historically improve the FVC, then patients will feel better and the quality of life will improve if we do it in a way that we don't give much toxicity. But knowing that nintedanib is very similar to other oncology medications like sorafenib and sunitinib, that We use commonly because although we know that the quality of life sometimes can worsen, we can make patients live longer, right? So based on the fact that the mortality here is kind of in a gray zone, how much we can make them live longer, it's the patient with pulmonary fibrosis. How much quality of life do you think they actually really get from it? Is this really demonstrated? Because from my point of view, of course, this was designed by a pharmaceutical company. The intended trial, the first, the end goal, the end point was just numbers, right? But how much they actually feel better? How much the secondary inputs that for me are more clinically important if you take them. How much numbers are we treating instead of patients? That's my main question.
So you bring up, that's a very good question. You open sort of a Pandora's box in the sense that what your question is twofold. One is, how do you get a drug by the FDA to get approved? And they don't accept quality of life in and of itself numbers. That's one question. The second question is, what is the significant difference in quality of life? Because they're all scores, right? Is 5 a perceptible difference? Is 20 a perceptible difference? And so I think that what's going to happen is when these drugs are used in the community, they'll be like prednisone and sarcoid, in that you give patients prednisone and sarcoid, they gain 50 pounds and they feel worse and their lungs are no better. I think that's what's going to happen with these drugs, that you're going to give it to patients, some of which have IPF, some of which don't, some of which have severe. They're not going to sense the difference in the decline of FVC of 100 mils. They will not perceive that. And if they have side effects, they're just going to stop. I think that's what's going to happen long term. So your question is, but it's sort of a two-pronged approach. You have to get the drug approved first.
So I gave you an oncologist, I'm giving you a hematologist.
Please.
When the calcium influx through the TRPV4, okay, what is the triggering the signal pathway from that?
Yeah, so we don't know the exact details of what's happening downstream of calcium. I can tell you that, well, we don't know all the details. I can tell you that what's happening is that actin is polymerized. And when actin is polymerized, it releases this transcription factor called myocardium-related transcription factor, responds to actin monomers. When the actin polymerizes, this transcription factor comes off, goes into the nucleus, binds with serum response factor, and induces transcription of smooth muscle actin to make myofibroblasts. I can tell you that that pathway is active. I don't know that there are other additional pathways that calcium drives, as there are many, as you know. And whether or not those are also important, I don't know that.
One last question. Is there any SMAD7 signaling going on?
Yeah, so good, yeah. So absolutely that if you take TGF-beta and inhibit SMADs, you block its ability to make myofibroblasts. That is absolutely true, and we did that in our cells. That said, if you inhibit TRPV4, you have no effect on SMAD2/3 phosphorylation. So whatever the effect of TRPV4 is, it's either parallel to or downstream of SMAD phosphorylation. So we're working on it.
Did I miss a question here? I saw a hand. I'm sorry. Go ahead.
Would it be fair to say if somebody came to the pulmonary clinic with an FVC of, let's say, 70%, right, and maybe they smoke, maybe they have a little bit of COPD as well, but they've got CAT scan findings suggestive of IPF, and we've got to get a biopsy, and it is IPF. So they're early stage. Would it be fair to say that the data supports the use of nintedanib as opposed to pirfenidone?
I would say that, admittedly, I talked about the selection of patients in the pirfenidone ASCEND trial. Given what you just described, I don't think there's a clear preference.
So I'm going to show you something, but I want you to think for when we meet at 11 on aging.
Who's holding the bat?
And aging, IPF and aging are very much related. Do elderly lungs have more expression or activity in this calcium thing?
Under duress, I will answer.
No. So we have a tradition here that we send our guest speakers back home with a Louisville slugger
which, when you remember it, you'll remember this crowd, remember your family in Louisville, and of course you can use it for more useful things at work. Okay? Mitch Olman, Medicine Ground Rounds, University of Louisville, January 15, 2015. Thank you, everybody, and thank you so much.